This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host. And today I interviewed Dr. Troy McGill to discuss direct access in the military. Troy is a physical therapist with over 25 years of experience and holds a diploma in mechanical diagnosis and therapy. Troy provided direct access physical therapy services within the U.S. Air Force for 20 years, and his Ph.D. dissertation was about the efficiency of physical therapists serving as a primary care musculoskeletal provider compared to family practice providers in a military treatment. In our discussion, we talked about the differences between PTs practicing in the military and in the private sector, the benefits we might see in how healthcare is dispensed if the military model was applied to the private sector, the experience of practicing as a PT in a deployed location, the current state of the PT profession concerning direct access skills and capabilities, additional duties PTs should have to be proficient in seeing patients through direct access, and much more. So if you feel this information is valuable, I encourage you to subscribe to our channel, click on the notification bell to stay updated, give us a thumbs up, and share with other clinicians if you might benefit from this conversation. Thank you for tuning in, and I hope you enjoyed the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today.
Fitter First, your first choice for the best Canadian-made rehab and fitness products since 1985.
Hi Troy, welcome to PT Pro Talk. How are you today?
I'm actually doing very well. How are you?
Doing great, and very excited that we made this work, and excited to talk to you about all your story, your career, which is pretty amazing. I was just telling you how amazed I was with your resume, so I'm very excited. So let's start talking about your background. So tell us a little bit about yourself, your career so far.
Oh, sure. So after I graduated from PT school, I decided to go in the Air Force. It was a great decision because it allowed me to do a lot of different things and to see the world, United States at least. And also as a physical therapist in the military, your practice privileges are just, they're very broad. And I think the military does a good job of actually using other healthcare providers up to their educational level. And so the military definitely did that with me, and it was a lot of fun. So so 20 years in the service, a little over 20 years actually. And I recently retired, almost 5 years ago. And after I retired, we moved back. So we moved back to Alaska, and I took a job initially of the large hospital here. And I worked there about a year as a manager, and then for the last maybe 3.5 years worked at a different hospital as the therapies director, and also had the cardiac rehab, also had the ortho neuro floor under my supervision as well. So we saw all the post-op knees and hips and so forth. I had a great nursing staff that was over as well. So it was a nice job. So here recently, 7 months ago, I took a position as the director for Orthopedic Physicians Alaska, and it's a physician-owned clinic, and so there's about 60 orthopedic physicians that actually work in the practice, and there's 45 physical therapists that we have over 6 clinics. And so those are clinics that I will manage. So it's actually been really interesting. The ortho spine docs are, they're very, very familiar with the mechanical assessment. So there's a spine clinic that we've actually started here in the last couple of weeks, and it's actually going extremely well. The hope is to just be the person that ends up actually sorting patients for the spine docs. They're surgeons; they want to do surgery, and it helps their outcomes if we're able to kind of sort patients for them, and they understand if actually physical therapy's been that the mechanical assessment has been actually tried, and so we can refer patients on actually to the providers that they need to see, and as mechanical therapists. So normally we can make those decisions pretty quickly with this patient. So it's been a lot of fun.
That's awesome. I think that's how it should be, right? We could screen, and then the ones that we feel like candidates for surgery, refer them out.
Yes.
So I'm curious to learn how the physicians were familiar with MDT. How was that process? Was like you educated them, or like is the culture? Like how did that happen?
That's a great question. I do not know. There were two of the orthopedic spine physicians that already were actually very familiar with McKinsey method, and I don't know how they learned about the method. However, I was actually very happy to support them, and so we're in the process of actually growing the clinic to pull in some more mechanical therapists. The state of Alaska's there's 5 of us up here, so it's not a very, very large pool to draw from. So
yeah, very interesting. That's good. Good to hear that. And so you said that you have different privileges when working with the military, right? So what would be some of the differences between the privileges working with them versus a traditional way of practicing in the U.S.?
Yeah, so the service was actually really nice because it allowed us physical therapists to act as the musculoskeletal gatekeeper. So for instance, if a patient called in to one of the base hospitals or into one of the base clinics, and so for example, that they had actually hurt their back, the person on the other end that was actually scheduling the appointment would ask them just a series of questions, and if it was determined that it wasn't an emergent sort of situation, they would refer that patient to physical therapy. So we would pull the patient right in. They would see us on the same day, so that was actually one way to get in to see the therapist. The other way is that the clinics that I've actually worked at almost all the time would have walk-in hours, and they may be like in the morning, so we can try to catch the majority of the people as they're actually coming on to onto the base or whatever. But we would just see those patients so just directly. And so the things that we could do as a physical therapist in the military, so there was a small formulary that we could order off of. The medicines were normally anti-inflammatories. There were muscle relaxants that we could order. Also, we could order dose packs, which sometimes were actually very helpful, with folks that maybe had a hot nerve or something. Also, we could order all the imaging studies, so CT scan, so we could do MRI, imaging studies, like X-rays and so forth. We could do that. Also, so lab stuff, we could order SED rates and look at different markers for inflammation and so forth. And so it actually really, allowed us to use the education that we have and also work these patients up quickly. And if there was a patient that we were seeing that we felt like this patient actually needed to see their physician, and we would just actually put that referral in, and they would go see the physician. Or if it was a back patient or something, and there were red flags that we actually found, then we would just refer the patient off to the emergency room, and they would go, seek care there. So it was a very fluid way to see these patients, and also actually very efficient. Because I think on the other hand, in the private sector, oftentimes the route to get in to see like a physical therapist is they'll go see their primary care provider. So that could be like a PA, it could be a nurse practitioner, it could be a physician. So they would do the screening and order tests, and then if they actually thought it was appropriate, they would put a referral in for physical therapy. And then that oftentimes can take a week to maybe 10 days to get in to see the therapist. It can be even longer depending on your location and so forth. And so, it's just, so we know that, from the studies out there that they support, the sooner we can see these patients. So normally the quicker we can get the patient back to work or so back to their life and the things that they would like to do. So I think it's a much more efficient use of physical therapy. I think we have the skill set, and I think there's a lot of pluses to doing things that way. There are some states that they're coming along to kind of actually catch up with that. I think there's several states now that have they've okayed PT's going to order X-rays and clear folks and so forth. Just initially, the information out of those states is that the PTs that have those privileges are really using those skill set set very, very judiciously. Yeah.
Yeah. So that's my next question about direct access, because we know each state's different. So I don't know if you have that information now, because it's a lot of states to keep up and know. Yeah. But in general, PTs are not allowed to order exams, right?
That's right. Yeah. As a whole, and I would say the majority of the states, they don't allow that. However, all of the states, 50 of the states have, direct access privileges, and they're limited and so forth based on the state, of course. But that's a step in the right direction for sure.
Yeah, and medication as well, right? PTs in general, are they allowed to prescribe like medication, anti-inflammatories, or not?
Not yet. I think there's actually one state, maybe Oregon or something, maybe California, that is allowing actually some, and I think it maybe through Kaiser, but I may be wrong, that they're allowing PTs to order some meds.
Yeah. And when you said about clearing people, I was reading on the APTA website something about that I don't know if it's already there or kind of walking towards that direction, that PT could perform some assessments to clear people in certain specific situations. I can't recall exactly if it's for I don't think it's work, but driver to drive, something like that.
Okay.
I don't know.
Right. Yeah.
Have you heard anything about that?
Well, so not so much on the driving. I think that occupational therapists oftentimes will do that, but there may be physical therapists that do that also too, that they do the driving assessment, the cognitive assessment and so forth, and make sure that the person's able to drive and actually, so physically able, obviously, but also that they have the cognition to be able to do that as well. Yeah. I think, though, on the clearing side, I think this is it's a gigantic topic because, there are some studies out that have actually looked at the referrals that PTs get. And the majority of the referrals that come from family practice docs or from nurse practitioners and also actually PAs, the script doesn't have a diagnosis. The script will just say pain. The script may say back pain, but back pain isn't a diagnosis. And so as physical therapists, so we're having to screen these patients all the time. So we're already doing that. And the diagnosis that we give these patients oftentimes is actually based on function. And we know often, so with back pain, so for example, on the McKinsey method and so forth, the classifications are actually based on function. And so we know that those are actually more valid than actually saying the person has an instability based off of an x-ray. And so I think we're doing the musculoskeletal screenings already. So we've actually demonstrated that we're very, very safe. So one of the studies that actually occurred, probably 15 years ago, looked at Army PTs. And the big concern actually from the AMA and some of the other medical providers is that PTs, that we don't have the education, that we're going to miss things, and that something that actually needs to be addressed, and we're going to miss it, and see the patient for treatment or whatever, and in the end, that'll be damaging to the patient. However, studies do not support that at all. As a matter of fact, there are some very, very large studies out there that have actually shown PTs are very, very safe, and the things that they actually miss are they're non-existent. And so there's a lot of support for direct access. And so oftentimes I kind of think about PTs kind of like actually where some nurse practitioners were, so maybe 30 years ago. So the AMA, the American Medical Association, they fought like crazy. They didn't want the nurse practitioners to have the privileges that they had. And, they've actually shown themselves to be an extremely valuable practitioner. So, particularly, in light of the limited resources that we have out in the United States right now, in terms of the shortages actually for primary care providers. On the physician side of the house, there was a study that I was actually looking at a couple of weeks ago that showed that less than actually 10% of med school graduates are going into family practice. And so that's a gigantic hole that PAs, nurse practitioners, that they're trying to fill, that PTs, at least on the musculoskeletal side of the house, would actually be able to fill that void very well.
Yeah, we'll be the perfect professionals to fill the void.
I agree.
I was looking up that information, and it was in regards to disability, that some of the states were introducing or could introduce some things in regards to disability. So that would be interesting.
Yes, absolutely.
And in regards to the doctor title of PTs, I'm not from the U.S. I didn't have my education in the U.S., but I heard from other PTs that have the doctor degree, that went back to school and got the doctor degree, that was more in regards to screening. So make sure that PTs can screen patients. I don't know if that's true or not. And I was going to ask you, if that's true, do you feel like this doctor degree are helping PTs to become better direct access providers? Is that the idea?
I think so. Absolutely. Yeah, absolutely. I actually think some of the DPT programs out there, and I don't know, maybe all of them, but they go into more detail on the imaging side of the house, on the pharmacology, also with with labs and the way to utilize that information. I actually think where the disconnect is that the DPT, the graduate, oftentimes will have the skill set, but they didn't get to practice it a lot out in the private sector because there's just not places for them to practice that way. Now, if they're able to get onto like a military base, they can work with the military therapist, and a lot of bases will actually take students that are actually civilians and work with them, and so that is the best way. Because I know the first time that I actually ordered medicine for a patient, I was like, oh, and it was something simple like Motrin, and I thought, oh, so I'm going to ask this patient to put this stuff in their bodies, and it was Motrin is an over-the-counter drug that anybody can get. However, it's a big responsibility. And so, they really need to understand the side effects and the way those drugs can interact with folks. And I also have to add, and you probably see this too, the majority of the patients that we see now, they've had an X-ray and they're on anti-inflammatories, whether they needed the X-ray or they needed the anti-inflammatories. And so, I think in the private sector, I think, anti-inflammatories and, drugs like that, they're way so overprescribed. And so some of the retrospective studies that have been these chart reviews that have actually gone back and looked at the radiology, the rate of actually radiology, so ordering, by PCMs that are not actually PTs, the majority of the notes, it's just almost actually standard to order an X-ray. They're not actually using clinical practice guidelines to guide that decision. And so some of that's actually tied to reimbursements. The hospitals, they own the radiology machines, they own the imaging machines, and they want to have actually patients in there. But in the end, it's hurting the healthcare system because it is just isn't making us so efficient. And there's a better way to do things, I think.
Yeah. But it's always someone is going to suffer. Someone, like you said, the people that wanted the patients to do x-rays. I was reading your paper. I'm just jumping ahead a little bit. That you mentioned about the study saved a lot of money, the approach that they had. But the people in the hospital were not happy about that because the number of patients that were referred to x-ray decreased significantly. So it's hard to fight against the system because you're going to be always messing with someone that wants to things stay the way they are because that's their role in the whole cycle, right? The whole care. So
I agree.
That's hard.
Yeah, and I just think if there was a better way to, if there's a test that's ordered, that there ought to be actually some way to justify that there was a reason behind actually ordering the test or actually giving the patient the anti-inflammatory, since that's something that physical therapists can do. But there isn't, there isn't a lot of checks and balances out there right now. And so I think actually, so comparing the military system to private practice, so the military system actually, for the most part, is socialized medicine. I mean, because everything's covered. It's very expensive, and fortunately, it only covers about 1% to 2% of the population. Because it's so expensive, and but trying to go to where it's just completely so fee for service, or you have these insurance companies that are also, they're basically dictating care right now. is the pendulum is just actually just completely the other way. So there needs to be something in the middle, so somewhere, and also I actually think there's a lot of power that the AMA has to dictate the way the system's going to be run, and so sometimes that actually lends itself to, in my opinion, skew things actually towards the physicians, and so they don't want to give up that control that they have, for fear that they're going to lose income. But the fact of the matter is, because actually PAs and nurse practitioners have actually moved in, the physicians, they're still as busy as they want to be. As a matter of fact, we can't actually fill the slots that we have, for family practice providers, and there's always going to be patients. So there has to be just a better way to do this, just more efficiently, I think.
And why did you say that it's so expensive that socialize medicine in the military?
Yeah, compared to the private sector?
Yeah.
Because the healthcare that we had was the healthcare that we had was actually very, very good. But it is very available. It is there isn't the cost containment that we have oftentimes in the private sector. The military tries to do that a little bit. However, they don't have the pressures of payers and so forth that they have to fiddle with. It's just a different system. Yeah.
Mm-hmm. I was just asking because it seems so nice. The system looks so good. Like the PTs, they have in the same role as in other countries, that they actually act more as kind of like a primary care in a way for musculoskeletal, at least. So I was like, that sounds really, really interesting. And I was like, I wish that could be like that in the whole country. But
Sure.
I was like, do you think that doesn't happen because of costs, or because you have those that are used to making money in the system and they don't want to give up power, as you said?
Yeah, I think probably both of those. I do actually think that in the private sector, the way that actually costs continue just to go up every single year, there's going to have to be some sort of restraint that happens. And the way the insurance companies actually work now is, if you're young and healthy, you pay a lot of money into that, but maybe actually 5 to 10% of the population that's actually part of that insurance pool, they use that money, and so they can actually charge a lot, and it's a gigantic problem, that's for sure. Yeah.
Yeah, and we were talking about the difference between private and military. Is anything that you feel like private, it's better than the military model?
I think there's I think that actually both of the models have a lot of positive. I think on the private side, I do think that the competition is actually very, very good, because I think it'll help to provide actually quality outcomes. That was actually one of the problems oftentimes, with the military system. Your paycheck was the same if, you had a very, very busy day, or if, you saw 3 patients. And, so there's good and bad to all of that. And I think actually, so kind of trying to find the middle ground is the bigger problem, because I actually like competition. I think that competition does, like I mentioned, help with the quality, and if you have a physician or if you have a therapist that is just subpar, the hope is that the system would actually kind of work to sort of cull them out. However, that doesn't happen a lot, because I know oftentimes people will just move from state to state to state if they have issues. And in the military, they do it a little different. If there's a provider that has issues, and oftentimes they're asked to leave, and they're discharged actually from the military. So they do a good job of kind of actually policing themselves, I think, sometimes.
Mm-hmm. And what do you think that the middle ground that you mentioned would look like? And do you think it's realistic to think about that model? Or do you feel like, no, it's never going to happen?
That's a great question. I think we sort of have actually socialized medicine now a little bit in the United States, because actually once you turn 65, then you go to Medicare. And so that's actually government funded. And if you're not able to pay your medical bills, and there's actually Medicaid you can apply for. And so for the most part, the way it's kind of funded now is that normally the government payers, they don't pay well. So the private sector payers, they pay better. And so they're the ones that are actually kind of keeping the system afloat now. And so they're going to reach a point, and you're starting to see that actually now, where there actually are providers that have determined that they're not going to see actually Medicaid or Medicare patients, because it's actually hard to make a living off of that. And so I think that a lot of the bigger healthcare organizations now, they watch their payer mix very closely, because you want to do what you can to actually care for the Medicaid and Medicare folks. But if it actually gets too far to one side, then that affects the bottom line. And there's always the argument between, well, is the bottom line actually being skewed because the physicians are making too much money? And so it's always actually back and forth and back and forth. However, I think it is a better system than if it was actually purely all just a government payer. I think you take incentive and the ability to try to make yourself better. I think there are some positives, the Canadian system, and also actually with the system like in Britain and the UK. But I also think there's a lot of issues with that system as well. And it's a tough question. Yeah, it's a tough question.
Yeah, who is making all the money?
That's right. Where's the money? Yeah. And the thing is, it's either, do you want the private sector actually dictating, or do you want the government actually dictating? And so, it's a tough question. Yeah.
Yeah, absolutely. And so I'm curious to ask you if you had specific training, which I read on your paper, and I think you did have some specific training to be more qualified to order those exams and read them and about the medication. So how did that work?
Yeah. So the first year in the service, you have a mentor, and normally it's a senior physical therapist. And so you begin to work under that person. They review your notes. They make sure that when if you wanted to order an X-ray, you had to go through them, and they had to approve it. And so the same thing with medicines, the same way with the labs. And the Air Force and the Army have a course. It's an advanced physical therapy course that they cover just a lot of that information in there. Also, you can get a mentor that's a physician that actually can review your notes, so they can sign off. And then, so normally the process was about actually 12 to 18 months. they would sign off and say, you're good to go, you're independent, your practice patterns that over the past year or so that you've actually demonstrated, they will allow you to have these independent privileges and so forth. And then that's it.
Very interesting. Yeah.
Yeah.
So you get.
Yeah.
Go
I was
ahead.
just going to add, it'd be so nice, so nice, during PT school to have the courses and so forth that cover that information. But so like I mentioned, that if you're not actually using that information, it's just information. But I think, having the knowledge of, when you're reviewing a patient's medicines and to understand the way that these medicines actually may affect the person's healing process or there's a bunch of, varied, side effects that these medicines can have and so forth. So that's actually very good to know. On the imaging side of the house, it's also actually so good to understand when you would order like an MRI with dye versus actually not, and so those sorts of things. But and also on the radiology side, there was a radiologist that would always actually read the studies for us. And so we didn't read the studies. Now, in a deployed location is a little different. So I actually read the radiology studies that I would order there. And if I had a question, I would find a radiologist in the hospital and actually touch base with that person, just to get a second set of eyes and make sure I was not missing something.
And when you say deploy location, I'm curious because my imagination here is thinking about the stands in the middle of the war. So you were actually working like in like a hospital or in a clinic, or you were like in the field?
Yeah. So not in the field. I was in Afghanistan. It was at the Bagram Hospital. It's in Bagram, Afghanistan. And so it's a military hospital. It was a level 1 trauma center. So we would get all of the worst of the worst would come into there. So they staffed it with one physical therapist, which was me at the time. And so you would typically work 6 to maybe actually 6.5 days a week. So, I mean, it was just, you were working the whole time you were there. So we actually saw all of the musculoskeletal stuff. And also, we'd see local nationals, and we'd also see the prisoners. And I mean, it was just crazy environment, to say the least. It was a busy environment. Yeah.
And do you feel like the type of problems that you would see were very different from like traditional private setting?
They really weren't. I mean, we'd see the same thing. You see a lot of back pain over there, actually from the active duty troops. So just because of the activities that they were involved in, it was so physical. The soldiers and so forth, the guys that were actually out that would come in, they may be in for a day or two, and so self-care, so trying to diagnose and actually give them some things they could do once they redeployed out to their area. It was so important to do. And so McKinsey, the mechanical diagnosis was absolutely perfect to have over there, because that's all they wanted. They wanted information to treat themselves, and it was just the way to go.
Yeah, I just imagine. So you can do a quick screening and send them doing their exercise, and hopefully help them. And what do you think about the model? So if you apply the military model in the private sector, what benefits that you think we would see in the healthcare?
I think it would help with cost for one, and the literature out there actually supports that. The paper the study that I actually worked on for my Ph.D. looked at actually cost, and so we looked at cost for radiology and medicine, and actually returned to duty. I think is what I was active duty at the time. So if the patient was actually managed by a physical therapist, their cost was actually less than half, and the return to work was about actually 2 times as quick as if the patient was just managed by their family practice provider. So there's a lot of benefits. There's a lot of benefits to that, and I also actually think that the family practice providers that actually want to deal with the medicine, so part of it, of just seeing a patient as opposed to the musculoskeletal side, in the end would be actually much, much happier. Because the thing is, oftentimes they don't want to see, they see them, the patient comes in with knee pain, they fiddle with their knee a little bit, and they send them to physical therapy. Well, so what you've done is actually wasted an appointment, which costs the system. And, again, like we talked about earlier, the patient has to wait to get in to see the provider that they need to see. And so sort of the mantra that I've always kind of liked is the right patient at the right time, actually by the right provider. And, the smoother that we can get that sort of process going, the better. And PTs would definitely help in the private sector to reduce cost. I think oftentimes people say that, but do they really mean it? And the bad deal is as a country, I think if the U.S. does not get a handle on that, the system's going to implode. And, the government's going to take over or something. I don't know what's going to happen. However, I think we're actually well on our way to something like that. I just think we really need to use the education of the medical providers that are out there, and because in the end, the patients benefit, and and if we can do what's best for the patient, in the end, that's going to help the system as a whole, I think.
Mm-hmm. Yeah. And I want to talk about the numbers from your study because I was very impressed. So I wrote that down to mention. So rate of medication use for PTs was 24% and family practice providers 90%. That's a huge difference, right? And then imaging use for PTs 11% and family practice providers 82%. Yeah, so it's a huge difference.
Yeah, so gigantic. I also think, the prudent use of anti-inflammatories, because we know anti-inflammatories can hinder the healing process, because there's a reason the tissues go through the inflammatory process. And so oftentimes I would see actually patients that were on anti-inflammatories, when they see me, but I would ask them, before you started taking the anti-inflammatory, so was your pain constant? And they're like, no, it only hurts if I move it or whatever the case may be. So clearly the patient wasn't in the stage of they weren't in the stage of inflammation still. And so some of those things are easy. Those are easy, simple questions. And so for the most part, that was the way that I actually determined, does this patient actually need an anti-inflammatory or not? I mean, it was extremely simple. On the X-ray side of the house, just using the clinical practice guidelines, particularly like with ankle so ankle sprains and so forth that I would see a lot over there. It's really, really easy to clear these folks and stop an X-ray. And over in the undeployed location, the X-ray and the CT scan was extremely busy. They were always they were just busy. So the less patients we could send them, the better. Now, if a patient needed an X-ray, then obviously they got an X-ray. But I think there's a better way than if actually somebody comes in and they've turned their ankle, then all of them get an X-ray. And, and you see that a lot.
Yeah. And I think it goes down to the basics of differentiating mechanical versus chemical. That it seems so simple, but
it does.
But we don't know why we see that many people taking anti-inflammatories and having X-rays when you know that it's not useful.
Yeah. Well, and I think probably like in defense of the physicians and the PAs and the nurse practitioners, they get actually sued a whole lot more than physical therapists. And so one of the things that would actually kind of switch if actually physical therapists were the musculoskeletal screeners, the rate that we're sued would actually go up. However, oftentimes the number of X-rays, the number of actually medicines and so forth, they're practicing this sort of actually defensive medicine because, they know that there's a likelihood they may get sued and that folks are going to ask, well, did you order them? Well, I actually did everything I could possibly do. But there's a way to justify, if you didn't give a patient certain medications or, if you didn't order an X-ray and the test out there, the prediction rules, the guidelines, they're valid. And I think that PTs would do that. And I actually think that the liability that we may have as actually private or seeing patients actually through direct access would actually go back down. So I think that would be a little shift. So for the way that PTs kind of think.
Mm-hmm. Yeah. It's a crazy system. And I know that you work a lot to save money for over your career, right? And save money cost to healthcare. Do you think, now maybe a silly question, but do you think that the private sector wants to save money?
Well, that's a great question. I actually think they say they do, but are they willing to do the things that they need to do to make it happen and to have some restraint, the way that they practice it? I would say actually right now it's, particularly up here in Alaska, as a medical provider, they're few and far between up here. And, so oftentimes they kind of have actually carte blanche as to, what they would like to do with their patients. And it's expensive, I think.
Because it includes change and people are resistant to change because it's going to change the structure, how they structure their business. And that's where I feel like the resistance is.
Absolutely. Absolutely. And and they say, that any new change you try to implement can take actually 12 to 15 years to run through that cycle. And those are little changes. They're not actually big ones. And so I think it's going to be an issue actually for the foreseeable future. That's for sure.
Yeah. And in terms of direct access for PTs, do you feel the profession is evolving as a whole? Do you feel like we as PTs are getting better practicing direct access?
I would say maybe. I think, that PTs, they need to be able to stand up for themselves better. I think one of the things that's actually been kind of an eye opener going from the military to the private sector is the way that PTs they're kind of viewed. They're almost actually still viewed as a technician. They get an order actually from the doc that says this patient with low back pain actually needs like a stability program. But then I've actually ran into this a couple of times. You ask the physician, so what is that based on? So why does this patient with back pain actually need a stability program? I said, well, that's what I give all my spine patients. So I said, so all your surgical patients, do they all actually get the same, so lumbar fusion, or do some of them actually get some different stuff based on actually the symptoms that the patient has? He said, well, it's all actually different. I said, well, it's all different with us too. And so that's why we just don't do across the board. So everybody gets a stability program, so for their back. And I think until we can get to the point where we really begin to stand up for the knowledge that we have and so forth, I think there's going to be that level that the docs are here, the PTs are here. In the military, I think it was a little more like peer to peer, and I think that in the end that everybody was happy with that. To that arrangement, because I think that communication actually flowed a little better. If PTs weren't fearful to go up and actually visit with the doc because they thought the doc was going to actually try to berate them or whatever. And I think we just have to get to the point that we're able to stand up, for the knowledge that we have. I think the APTA they do a decent job. I think that that PTs just need to be not considered like ancillary services, but actually considered just a provider. And I also think that that's interesting. So when we get an order, so in the service, in the military, so I would be consulted. In the private sector, so I'm actually given an order. And or like a referral. And I just think it's interesting, because the docs actually consult other docs, but they send an order to a PT. And the crazy thing is, oftentimes they don't even know what PTs do. So it's baffling to me, I think. Yeah.
And if all the doctors are prescribing the same stabilization program for their patients, is the same technician level that they accuse us to do. If you do the treatment for all back patients the same, we are technicians as well. And I just think people don't stop to think about it, or maybe get specialized in something and I don't know.
I know it doesn't make any sense to me, and I just said I've always thought that if everybody gets the same exact thing that has actually back pain, why do they need us? They just need a box that the patient gets back pain.
Why do you study?
Yeah, absolutely. Yeah, absolutely. Anyway, but I think the DPT degree, like you mentioned earlier, I think over the years, I think that was a good move. And that I think the doctorate level, the knowledge base that we have, I think is actually definitely at the doctorate level, and to be recognized as a doctor, I think is actually very important.
I just don't feel like it's explored enough by the system.
I agree.
Yep. And what other duties that you feel like PTs should have to be better at seeing direct access patients? Is there anything else that we haven't mentioned that you think it's important with looking at your previous experience?
I don't. I think they need to be, PTs should be like included. The physicians and the PAs, because the company that I'm with now, there's a spine team, there's a knee team, there's an ankle team, there's a hip team. Those all actually consist of so everybody actually but a PT. So the PTs, they need to be actually part of that team. They need to have a voice. As a matter of fact, the physical therapist, so we're the ones that end up actually spending the majority of the time with the patient anyway. So having that relationship is actually critical. So one of the reasons I actually think that PAs are so well supported is because they're in front of the doc a lot. So the doc understands the knowledge that the PA has. So I often think PTs, they don't actually fully understand what we do. So one of the things that I actually saw in the military worked extremely well. So this was down at Eglin Air Force Base down in Florida. So when the docs would do their follow-up with their post-op patients, so they did that in the PT clinic. So the physician would actually come down to the clinic. They would have their PA. So the doc, the PA, and the PT would see the patient together. For their follow-up, the doc would actually move the joint, which oftentimes doesn't happen now. And so if the patient had actually questions, the doc, the PA, the PT was there, and so things could actually be kind of settled. And it's just a more efficient way to do the follow-up, and it allows the physical therapist to talk a little bit in front of the doc, so they understand the things that the PTs are doing. And I actually think until we get to that point that we have that sort of collegial sort of relationship, I think we still have some work to do in that area. But I actually do. I do think so. Direct access is a good thing, because the docs, they'll take notice, and they'll and it depends. If we end up actually referring back to the doc and so forth, so that's a good way to kind of communicate. And I just think we have some work left to do.
Mm-hmm. Yeah. And I like what you said about being like in a team, because we don't have contact with doctors usually. So being able to communicate and show them that we also know what we are doing, and build that trust, and they see that they can refer patients, that we are actually knowledgeable, we know what we are doing, and work better as a team, understanding each other's role.
Absolutely.
In that scenario.
Yeah. And I think, trying to take the egos out and, do actually what's best for the patient. And I think if we can get there, so I think if we can have all of the stakeholders actually kind of together, stakeholders that are involved in that patient's care, your outcomes improve, patients are happier, the docs are happier, definitely, for sure, because their follow-up is actually more complete. So there's a lot of pluses to being like a member of a team, I think.
Yes, absolutely. And do you see, Troy, the direct access working just for the musculoskeletal conditions, or do you see that in general in other PT specialties? Yeah,
that's a really good question. I actually think the way that it's kind of set up actually now is just on the orthopedic, the musculoskeletal side right now. I think that's actually where we kind of shine. So I think with other forms of PT, it's actually very, very important, because oftentimes there's actually much more of a medical component that's contained in the patient's case, like on the neuro rehab side. So like a post-stroke patient, you definitely want a physician in that, in that loop and so forth. And so that, I think the way that it's actually kind of set up, it's just an easier model to have the doc that's so actually kind of managing care. However, the PTs they're obviously a vital component, that patient's care, and they should be part of that, the rehab team. So.
Yeah. I think every specialty is different.
Yes, it is.
So we gotta act properly.
Yes.
Troy, you working for 20 years in the military. Now you're retired, right? Do you miss seeing patients the way that you used to see them when you were working with the military?
That is a good question too, because I thought, when I actually retired, I was like, I will never miss this, getting out of the service. I mean, it was a good career, but I was actually ready to retire. But I think over the last couple of years, I am actually starting to miss it a little bit. Just the structure, the camaraderie that we had in the service, and it was like a big family. So the patients that we would see, that was our mission, to get them actually healthy and to return them to duty. And if it was in a deployed location, was even actually more important, because if the patient had to be sent back home, so to backfill that person's position over there was about $60,000, because that person would have to be shipped home. They'd have to ship another one. So into theater to actually take his or her place. And so it's just very expensive, but working together, because I always felt like that we were all part of the same team. And so that was fun.
Just imagine how intense
Yes.
it must be working like that. And what was the most time that you stayed deployed in a location?
So 6 months, 6 or 7 months in Afghanistan. Yeah.
Okay. Yeah. That's a long time.
Yeah. It was a long time.
Okay. I'm just curious, asking questions. Anything else that you want to add before we transition to our final questions?
Not that I can think of. Nope.
We talked a lot about a lot of different topics. And do you have any resource of information that you recommend our listeners to go to? Anything that you like in particular? It could be related to the topic, or it could be just something that you like.
The APTA, there's a site. They've got a nice site on direct access now, I think. And there's a lot of good information in that site. I also think that being a member of the APTA is actually very important, because they're the ones that are actually up on the hill, up in DC, actually fighting these battles. And just to make your voice known in the realm of actually direct access, that it's something you support, I think it is very, very important. So I think the schools, the PT programs have actually, stepped up, and the educational level is actually up so several notches. I think that they need to push hard for some of these hospitals to allow actually PTs to begin to utilize some of the skills that they learned in school, and just continue to push.
Yeah. And what would be the best advice you give to clinicians that are starting their careers?
I would say, so I had a really good piece of advice when I first started, and there was a colonel that was over the PT clinic in San Antonio, down at Wilford Hall, that said, so your first couple of years, Troy, just see all of the patients you can, and in the hospital. So we would see inpatients and also outpatients. We did was actually wound care, there was aquatic therapy, there was, so we would work out on the basic training side and actually work with basic trainees. We'd work with the PJs, the pararescue guys, which are the special ops medical providers for the military. So very, very fine-tuned athletes. They were incredible. But I had a chance to work in all of those. And then at the 3-year mark, he said, so now actually find something that you really like to do. And actually, you take every course, you become the expert in that area. So make yourself actually kind of stand out. I would say, so what I've actually kind of seen in the private sector is PTs actually want to be generalists. So on the orthopedic side, at least, I actually think the future is that actually PTs, they need to specialize. So just like the orthopedic providers. So you don't see an orthopedic provider that'll do your ankle, your knee, your back, your cervical spine. They specialize. And, by doing that, I think they kind of set themselves apart. And so I think that it's okay to be actually kind of a generalist. However, my thought is the more that you're able to specialize, the more you can make yourself actually kind of stand apart, the more that you're going to get actually recognized. And, in my mind, that's the way to kind of go.
Yeah. Yeah, because you know a little bit of everything and not much of anything.
That's right. That's exactly right. That's right. And I think when you actually, so you get a reputation as the knee person, if you've got a runner with some knee injuries and blah, 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 people start to seek you out. And, and that's the reputation, the credentials I actually think that we need to have.
Yeah. And final question, personal qualities or abilities that you think are important to be a successful PT?
Oh, that's a good question too. I have always thought that we need to have like a larger sort of like an education component because we teach all day long. You're teaching your patient, all day long, and the skill set to do that actually takes a while. And I also think that a little bit of more like on the psychology into things, I think would be extremely helpful as well. So I think a little more focus on patient education and on the psychology of actually working with patients. Because the deal is, so we're teaching and so we're trying to get these people to change habits oftentimes. And so we understand the mechanics of it. However, if we never ever, cross that over to where the patient actually fully understands and they own that information, we're going to struggle and we won't have good outcomes.
Yes. And it's something that we are not trained, and you learn over time with your patients every day and get better slowly. So it would be useful.
Yeah, absolutely.
Troy, I just want to thank you so much for taking the time to be here and sharing all your knowledge. I am amazed with your resume, with your experience. So I just wanted to say thank you for all your contribution, all your service, and everything that you've done for the profession and for the country. And it was an honor to have you here on the show. So thank you so much.
Oh, thank you very much. Very, very nice to meet you.